Well, hello and welcome. My name is Jeff Rose. I'm Chief of Cardiology for Sanger Heart and Vascular Institute, and I'm also a member of the Board of Advisors for the Carolinas Physicians Alliance. Our group meets every year to discuss trends in healthcare, and we recently had an opportunity to review some of the events that are shaping this so-called volume to value transition that we all have heard of. When we met earlier this year, we didn't have an opportunity to capture the conversation at that time, so we're recreating that symposium here for you today. So we really appreciate the time that you're taking to listen in and to hear about some of the trends that are shaping healthcare today. So what will follow is a presentation of some of the efforts that have happened by members of our organization within Atrium Health and within Carolinas Physicians Alliance. You'll hear from Bruce Cohen of Ortho Carolina. You'll hear from George Hart from Metrolina Nephrology, and also from Bennett Thompson from Atrium Health, and some of the efforts that have undergone or taken place over the course of the year, really to look at the continuum of healthcare and coordinate action across time and space. So we've all heard about volume to value. Let me just talk a little bit about that and some of the issues that are really shaping the healthcare landscape that I think that all of us should be aware of. This slide that you see before you, this is Medicare spend. So when we think about healthcare spending, of course, very complicated, from out-of-pocket spending to private insurance, but I think for most of us involved in medicine, we're aware of the impact that Medicare has on the whole spending equation, if you will. To orient you to this slide, this is the spending that we have seen from present day, so statistics from about 2017, to what is projected in terms of spend through the next decade. So presently, Medicare is spending about $588 billion. But because of population growth, and we're aware of the aging of the population and the 10,000 of Medicare every day, we are on track to be spending over $1.6 trillion over the course of the next decade. If we look at this slide, this orients us, a little bit further. You can see that today we have about 57 million in the United States who receive Medicare benefits. Because of just the actuarial nature of things, this will expand to 82 million by 2030. What's also compounding this challenge, when Medicare first started back in 1966, actually, the ratio of workers to beneficiaries was about 4.6 to 1. We're presently at 3.1 to 1, and soon to be 2.3 to 1. So what this means is that we have a tremendous number of beneficiaries who are increasing, and we have fewer workers to support that. And that creates some real challenges from an economic perspective that I think we need to be aware of. If we look at just one piece of that, this is a graph of the Part A portion of Medicare, the so-called trust fund. This is the portion of Medicare that comes out of all of our paychecks every week or every month, and this is the part that funds the Part A portion of Medicare, which is the inpatient spend. And to date, just like Social Security, that money has been put into a trust fund and has been spent. But you can see from this curve that the spending rate for Part A is continuing to increase, such that the trust fund is running out. And the trust fund depletes from an actuarial standpoint somewhere around 2028. More recent projections project 2026. What that means when that happens is that the monies that come out from payroll and so forth will fund about 87% of Medicare's costs in the hospital and in the hospital-based setting. So these are major factors that are just influencing the whole conversation about healthcare, the cost of healthcare, the financing of healthcare. And I think all of us as practitioners have, realized this to some extent. But we're starting to see this in sort of major policy changes each year from Medicare in terms of, what is happening. I think we're all familiar with MIPS and MACRA and so forth, and these are programs that have been put in place to try to bend the cost curve, if you will. So while those efforts are important, we're just in the beginning stages of that, and we're going to have to become very disciplined in this type of work. So we're very happy to share some of the efforts that have been going on over the course of 3 or 4 years prior to today by a number of members of our organization along this transition, just for your general education about what has been happening and just to help us as we engage in these efforts moving forward. So I'm going to stop here, and I'm going to ask Dr. Bruce Cohen to join us here at the podium. He's going to take us through a presentation on some of the work that OrthoCarolina has done in this general space. This will follow by 2 more presentations as mentioned, and then we'll have a panel discussion to sort of probe these issues a little bit. So again, thank you for your attention, and we welcome Dr. Cohen.
Thanks, Jeff. I'm going to go over OrthoCarolina's experience in these advanced payment models. So we'll talk about our experience somewhat briefly. We'll talk the majority of the time about our experience in the BPCI, which is the Medicare program, the challenges that we see with a lot of the variability in both the BPCI program, but also many of these additional programs, as well as some opportunities in the future. And then, how are we taking this, what the lessons learned, and expanding it to the private payers? So our experience has been somewhat varied. The BPCI program, which is the Medicare Retrospective Bundle Program, we participated since the program launch. We started with all the available musculoskeletal bundles that we could participate in, and very quickly, and I'll explain why, we dropped the spine and the trauma portions of this. It was a fairly slow ramp up. We were not very bought into this, and we didn't perform very well in the initial year of the program. But since that time, we've had excellent results and really have both improved the care the patients are getting, but also the savings that are being experienced. Our private payer experience, we're participating in both prospective and retrospective models, commercial and Medicare Advantage, and inpatient and outpatient bundles or coordinated care programs. So when we look at the BPCI program, most of the focus was on the portion of the acute spend in the post-acute phase of this. If you look at this graph, this is typically the entire spend, but look at the size of the post-acute, which is in the orange and the red standpoint. So in the post-acute side, so after that patient leaves the hospital, it was high cost per case, and there was a lot we could do to influence or decrease the spend. Readmission, obviously, is something that we all want to prevent, but it was a small portion of this. And so we really focused, and most of the folks in the country focused on the spend in the post-acute phase. So we look at this, our focus was really to drive down the post-acute spend without affecting the readmit. So obviously we wanted to deliver better care, decreasing our readmission rates, which we did. And if you look at these graphs, our post-acute spend went down, and our readmit numbers and obviously the spend that comes along with it went down as well. So how do you drive value in this in the musculoskeletal arena? It's decreased utilization of rehab stays, decreased utilization of short-term nursing facilities, or skilled nursing facilities, decreased utilization of home health. We did all this despite decreasing the readmission rate. So the concerns that a lot of folks had was if we're sending these folks home, we're decreasing the home health spend and home health utilization. They're not going to rehab facilities or skilled nursing facilities. Were we going to increase our complication rate and our readmission rate? And we didn't. And so a lot of that was through more care navigation, more of a concierge type approach to this. A lot of touches with the patient, with our patient navigators, who were both licensed navigators as RNs, but also just some clerical folks, just to make sure that these people were doing what they were supposed to be doing. And what we found was not only did it decrease the cost, it increased the satisfaction and decreased the complications. So we did this all at the same time lowering that post-acute spend. So there was inherent variability that made it difficult for us. So arthroplasty was the most homogeneous population and the least amount of variation, and we did extremely well in this. Spine was very difficult for us. The way that the episodes were clumped, we basically had a huge heterogeneous spread of the acuity of the patients, the spend of those cases, and the level of complexity of those cases. And then it got worse when we had increasing age, particularly in the trauma or the hip fracture population. These patients were not optimized. Obviously, you can't optimize before a hip fracture because you don't know what's going to happen. So as the age increased and the the spread of the patients and the diversity of the patients changed, then we saw this variability in the results. And that's why we dropped out of the trauma bundles as well as the spine participation. There's still opportunities that remain in these programs and in this patient population. When readmissions occur, the costs go way up, so you can erase all your savings on the post-acute side with an increased readmission spend. The average readmission spend that we saw was close to $10,000. So our opportunity was to risk assess and identify the high-risk patients, optimize to lower the readmission, and that's how we've gotten to our patient optimization. We also need to electronically surveil these patients to monitor them, especially if it's a challenging discharge. Those are the ones we need to surveil pretty closely. So it's very important that these patients are monitored. They get constant communication from our staff, and we found that was probably the best way to move the needle with this. So how do we take our experience in Medicare and extend that to the private payers? And that's, Medicare Advantage is an emerging sector that we all need to be aware of and need to be very proficient in. So the savings opportunities are very similar to what we saw in the BPCI program. The MA or the Medicare Advantage patients tend to be younger and slightly lower risk, so lower variability can translate to a better ability to move to a more prospective payment model. We see this as the next large area of opportunity. In the commercial patients, we have fairly extensive experience in the commercial patients with bundled payments, and what we're seeing is extremely high patient satisfaction, low complication or almost zero complication rate in most of these patients. The pain relief and patient satisfaction is really high, and we're doing this while saving 10 to 20% per case. This requires an investment, and this investment is significant. The care coordination piece, the software piece to follow these patients, follow them with data as well as communication with folks, is an investment that's important. But it's a critical success factor. You can't do this without an upfront investment. The next opportunity in musculoskeletal care, particularly in arthroplasty, is the conversion from inpatient to outpatient, which will significantly lower the facility cost per case, and it will allow us to be competitive in the market, but also to increase that market share, which can significantly improve the bottom line. Thanks.
So, Bruce, thank you. You touched on a couple of critical points, and that's the phase of care analysis at each phase along the way of care, and then the work that it takes across the continuum to monitor the patients, to track outcomes, and to improve. So we'll follow up on some of those points in our panel discussion. We now welcome Bennett Thompson from Atrium Health to the podium, and Bennett will give us some insights on some of the work that has gone on within the organization with respect to episodes of care.
Thank you, Dr. Rose. I'm going to present from just a little bit different angle. So this is the hospital perspective and post-acute, and we'll go through what we went through with the BPCI program beginning a couple years ago. So that's what I'm going to talk about. Basically, why participate in a bundled payment program from the hospital's perspective? There are a few reasons. The first, obviously, the first two are probably the most important. Number one, we want to enhance the patient experience, and number two, we want to improve the quality of care. So anything we do, if it affects those two things, we want to make sure that we're paying attention to that. The third piece, and probably very important for how we perform, is strengthening the clinical integration and partnership with physicians in the particular areas that we're participating in. We also would look to achieve clinical efficiencies and cost reduction efforts which have a halo effect. So in other words, they're going to apply to cases outside of the bundle if we do the work right. This is a scenario where if we do the work right, all boats rise. We're looking to drive incremental growth, and that's a limited opportunity with some of these areas, but we do think if we get better at this, we can drive incremental, even regional and national growth in some of these areas based on the quality, service, and costs that we're generating. We certainly want to prepare for future employer and payer opportunities, and maybe even more than that, prepare for assuming risk. So make sure that as a hospital system, we're doing the right things and preparing for what things may look like in the future. So our participation looked like this. We participated in the BPCI, the Bundled Payment for Care Improvement Program with Medicare, which started in April 2015. We participated in 2 episodes out of 48 possible episodes. And the ones we chose were stroke episodes at Carolinas Medical Center and at CHS Pineville. And we chose those episodes largely because we looked at our baseline performance and our current performance and thought that there was a limited risk of loss, and at the same time we could learn how the program worked, how Medicare was designing the program, and what we needed to focus on to do it right. Meanwhile, while we were participating in BPCI, CJR, or the Comprehensive Joint Replacement Program, became mandatory in April 2016, and so we were also participating in that program at 6 of our facilities. I'm going to focus on our participation in BPCI today. So a couple things about that program. The reconciliation period, in other words, the period at which they look back at your performance and compare that to the baseline, was quarterly. So every quarter we got an update on how we were performing. The baseline period was 2010 to 2012. And our participation actually ended earlier this year in February as we ramped up for participation in BPCI Advanced. So we elected to pull out of that program to enter into the newer BPCI Advanced program. When we look at our performance, and this speaks a little to what Dr. Cohen was referencing earlier around variability. With stroke patients, there is a tremendous amount of variability. And so what you see on this slide is 2 parts of each episode. There's an acute care portion, which in this case on average is about 30%, and a post-acute piece, which is about 70%. And if you follow the green line, all of our cases for this period that I selected are represented by one of these columns on this chart. The green line shows our par level, so that was what we were trying to do better than. And if you look on the right side of the chart, you'll see episodes for which most of the episode was the acute care portion. And there are lots of different reasons for that. A patient could have entered a hospice program. They could have done really well in the hospital. The patient could have expired while they were in the inpatient setting. So there are lots of reasons why you may not have a very high post-acute. And then on the far left of the page, you have what I would call the worst case scenarios, where we have multiple readmissions, multiple post-acute episodes of care. And so on the right side of the page is where we wouldn't have done well compared to the baseline. So if you think fundamentally, what you're trying to do is to get as many cases close to the middle as you can, but also to reduce what happens on the end, so that you're looking for that variability. A nice thing about this is you can really drill into the patient level information for those high outliers and low outliers and learn what happened, and maybe help apply some learnings to other subsets of patients. I would tell you, based on our analysis initially, we thought there was a pretty good opportunity that we would perform well to the baseline. And throughout the program, really just based on the variability and the better words, probably the heterogeneity of the population, we really saw just up and down performance overall in our participation in the overall program. We were net positive, but it wasn't by a large margin. So there's a lot that we learned, but a lot that also is just up to variability. So what are the success factors, at least from our perspective, for strong performance? Number one, I just hit on this: learn from the outliers, dig into the data, understand what may have gone wrong. On the positive side, if you look at the better performing outliers, you can also figure out what went right and then apply that to the population. Obviously, standardization of care and education is important. Our care management partners on the discharge planning side were huge in this. So they talked to patients. We had scripting that helped patients understand the program and what we were trying to do, and then standardizing how we discharge those patients, particularly to a preferred network of skilled nursing facilities in many cases. Managing the transitions and care coordination, extremely important, and going forward in any bundle, whether it is a Medicare bundle or a commercial bundle, managing that transition and care coordinating the patient in the right way is critical. I mentioned focusing on the high quality and low cost post-acute care setting, which we did through the creation of networks. So essentially we're making sure the patients go to the setting that's going to perform the way we want. And by doing so, we will improve our post-acute care performance in aggregate. Certainly a focus on patient experience and engagement, although with the stroke population, an interesting thing about this group is we didn't know who they were when they were coming in. Most of the patients come in through the emergency department, so there's some added challenges with the identification of patients and education versus a total joint replacement where many times the patient knows they're coming for that. And then probably last but certainly not least is active participation from subject matter experts. Probably first on the list would be the physicians within neurosciences who helped guide the care protocols, but also care management, post-acute, physical therapy, all those involved in the decisions around placement once a patient leaves the facility, because as you remember, 70% of the cost is in the post-acute setting. From a systems standpoint, what do you need to have in place to know how you're doing while the program's going on? Number one, you need standard reporting. You can develop this internally. You can work with an outside vendor, but you need good quality information to know what's going on. CMS is obviously, for the bundled payment program, feeding you claims data, but you have to be able to take that and analyze it to understand where to improve. Connectivity and communication, can't overemphasize that, and that's among all people who are a part of getting the patient identified in the hospital, triaged, placed, monitored throughout the entire episode. That leads right into the next piece. You have to have some method for identifying patients, particularly those that are not elective. That proved to be a fairly challenging problem for Atrium as we looked at stroke patients coming in, particularly those that may have had a different diagnosis initially and maybe their final diagnosis was a stroke DRG. So identification and tracking, reconciling the information we got from CMS back to our information, and then finally just overall data monitoring. So this could be leading indicators. Also, it could be the CMS data. Just in summary, our approach to this and the reason we're comfortable moving forward would be population risk stratification first, so sorting out the patients that require the most intensive management. Then I mentioned care management implementation, that process, getting the patient to the right place, building the networked options in post-acute, and finally, and I haven't mentioned this yet, but hospice and palliative care is a huge part of this because a patient, at least under BPCI, once they enter hospice and palliative care, the clock stops ticking, in other words, for the bundle. So that was a strategy that we employed with the stroke patients as well. So that was a quick high level of our participation in the BPCI program. We feel good about it, and because of that, are choosing to participate in a few more bundles in the BPCI Advance. So we hope to come back and talk to you about what we learned through our participation there. Thank you very much.
So, Bennett, thank you. We'll have a chance in our panel discussion that's upcoming to talk a little bit more about what's happening in the CMS space with respect to these programs in terms of the next generation of bundles. We've heard from Dr. Cohen and from Bennett Thompson around care organization, around episodes of care where there's a pretty discrete beginning and, if you will, end in terms of that care. And we've begun to hear some of the challenges and some of the tools and resources that are needed to be successful. George Hart from Metrolina Nephrology is going to join us now and talk about this same concept, but over sort of a broader spectrum, and that's over a chronic disease and that of end-stage renal disease. And George is going to share some of the work that Metrolina Nephrology has done to take this similar approach to a disease state. So welcome, George.
Thanks, Jeff. Glad to be here and have an opportunity to share. We had an opportunity starting 3 years ago to participate in what's really a comprehensive Medicare cost savings plan, referred to by the acronym ESCO, which stands for End-Stage Renal Disease Seamless Care Organization. We are partnered with Fresenius of North America, which is the largest provider of dialysis services, not just in the United States, but in the world. So ESRD is a challenging problem for several reasons. One, as Jeff mentioned, it's a chronic disease state, so it's not an episodic issue. ESRD patients represent 1% of the Medicare population, but 7% of the Medicare spend. $33 billion is spent annually with an average cost of about $87,000 per patient per year. The challenge is that as we're on the leading edge of the baby boomers still, there's an increased incidence. Care is leading to increased survival, which leads to increased prevalence, increased costs. These are a complex patient population with a heavy disease burden. North Carolina has 18,000 ESRD patients with an annual cost of about $1.4 billion. The Charlotte metro area, 4,000 ESRD patients with a cost of about $320 million. Many stakeholders in this, and we're all trying to find the sweet spot in this continuum between transactional care and value-based care, which creates a tension as we try and navigate this. With the patient in the center, you have hospitals, you have dialysis companies, you have nephrology practices, you have CMS and Medicare, all with their own perspective. To make it work, several tools were implemented. I think just like both Bruce and Bennett have mentioned before me, care navigation was a large part of the strategy that was implemented. This involved remote monitoring of when patients actually hit the seat in a dialysis unit. If they didn't show up on time, they got a phone call. 24/7 monitoring of what goes on in the emergency rooms, which is a challenge as you're trying to navigate not just one hospital system, but multiple hospital systems with multiple facilities in a market. From our standpoint, we invested in advanced practitioners who became really the backbone of the care delivery model in the dialysis units. We stepped up and ramped up our presence. There's care coordination, a lot of emphasis on the transitions of care, so hospitalization back into the dialysis unit, meeting with patients. A huge issue is medicine reconciliation. Our patients average as many as 15 medicines, so making sure that the interactions are appropriately managed is quite difficult. We had several clinical interventions, including CritLine, which is a intravascular monitoring of blood volume, which helps us to control volume in patients during dialysis. Volume overload would be one of the leading causes of hospitalization. We had ClearGuard and VascuAlert, which are both methods of either decreasing infection risks in patients with permanent dialysis catheters or monitoring their dialysis accesses, which is another leading cause of hospitalizations. We had ER diversion strategies. In other words, we chased patients through Care Nav when they missed treatments, trying to reschedule treatments. We created a new dialysis opportunity for patients where we could take them if they showed up in an ER, and instead of having them admitted to the hospital, have them divert to an outpatient facility. Doing all of this, 30-day readmissions decreased from about 33% to 19% when we could confirm that there was a transition of care visit performed. So what did we learn from all this after now 2 years? You got to be comfortable with ambiguity. You're going to make decisions and take risks before you have all the facts. Data rules, and unfortunately, when you're dependent on Medicare for data and claims roll out or run out, you're always a year or 2 or 18 months behind in the data. You also have trouble. In our world, we had trouble because about 18% of the data was carved out if there were any mental health diagnoses. So whereas hospitals have a real incentive to include all the different types of diagnoses, including mental health diagnoses. These came back to bite us because we lost about 18% of the data, which during the year you're trying to adjust and you don't have that data, but you're still held accountable at the end when all that data is rolled back into the totals. The savings take a long time to calculate. We didn't know performance year 1 until performance year 3 was starting. Federal laws now and state regulations apply to fee-for-service in a way that makes it difficult to perform value-based care. For example, transportation. There are laws that get in the way of your ability to transport patients and pay for it. We were able to get waivers on some of this, but the waivers had strings attached. So instead of getting a complete waiver where we could transport a patient anywhere, we could only transport them to places that were included in the ESCO. So that means that we can't transport them to a surgeon's office or transport them to the hospital or even from the hospital back to us. So those kind of limitations make what seems like a great idea practically not very usable. You have to have partner engagement. We certainly increased our relationship with Fresenius. We've reached out to CHS, to Novant, and all those things are working. It's just quite difficult and complex as you try and navigate all this. This national initiative has expanded. What started as 13 centers nationwide is now up to almost 35 programs nationally. So how did we do? Well, nationally there were 16,000 patients that began all of this. In Charlotte we had almost 1,300. The total spend, again, was $1.4 billion with these 16,000 patients. The total savings nationally was $75 million, or 5.3%. In Charlotte, we saved $2.4 million, which is 2.5%. So lest you leave thinking that Charlotte underperformed, you have to understand that if the average spend nationally was $85,000 per patient per year, Charlotte entered the program with the lowest cost per patient per year nationally, roughly 20% below all the other national data. So we were very proud of saving anything in year 1. With that, we'll take whatever questions come.
George, thank you. And, you know, certainly impressive results from what you were able to achieve early in the experience. But I think that, well, as we'll talk about in the panel, taking a look at care across the entire continuum identifies that there's opportunities to make improvements even when the baseline level of care is superior, as we've seen from your leadership and your group's leadership here in our community. Welcome to our panel discussion. We've had a chance to go through in some detail some of the efforts that have been ongoing within members of our Carolinas Physicians Alliance in the volume to value transition. And as we explore this a little bit more through a panel discussion, we'll maybe just take a moment or two just once again to level set. So when we look at the factors that are shaping healthcare in the U.S., we're spending upwards of 18% of GDP on healthcare. The closest Western nation to compare is about 12%. So we already spend a lot of money on healthcare. If we look at performance writ large in terms of population health and so forth, mortality statistics and so forth, as a system, we don't reliably do very well along those measures. And this is what's happening before the Medicare population increases by 1/3 over the course of the next decade. So the challenges that we're facing are real. And it's driving a lot of policy decisions, which has gotten us to this place of what you've heard from the previous presentations are experimental projects, new projects where we're learning about how we can approach care across the continuum. Before we get into some of the details and some of the lessons learned and maybe some of the landmines to avoid, and so forth. Let's just level set a little bit more. We've used some jargon in the talks, and I just want to take a point to clarify that. So we've talked about BPCI and BPCI Advanced. I'll start with Bennett. Can you just kind of walk us through what that is and what those programs are?
Sure. So BPCI is the Bundled Payment for Care Improvement Initiative. It's a Medicare program. BPCI Advanced is their latest iteration of the BPCI program with a little bit amended rules, and that one extends through 2023. The basic premise of the program is that Medicare will compare your performance in a retrospective way to a baseline, and they have several different methodologies that play into how that baseline is set, but it's essentially a historical baseline. So the idea is if you perform better than your baseline, then you benefit, and Medicare would theoretically pay you money back because the fee-for-service model still applies here. So physicians get paid the same way, hospitals get paid the same way. It's a retrospective reconciliation. If you spend more per episode in aggregate than your baseline, then you would owe CMS money back. So there's some other nuances to how that's structured, and Medicare certainly takes a percentage out to fund the program, but that's a nutshell of how the program works.
Terrific. So now we've heard some early results from George with respect to care for patients with end-stage renal disease, some real-world work from Bruce. The question is, as your experience unfolds, do these programs work? Is this the right approach?
I think it's a great beginning. I think what we're learning is that you can improve care and save money, and that, to your point, we don't need to throw additional dollars. What we need to do is to think, how to be more efficient and to, in some ways, get out of our own way. There are a lot of regulations now that are in place that were, created with good intentions, but have, hamstrung us in our ability to do things. What we learn is when we can break down these traditional barriers and silos, that we can definitely improve care for patients.
So, Bruce, following up on that, walk us through some of the practical things that you did differently or learned in terms of just day-to-day care that were different with this perspective of looking at care across the continuum, approach to in-hospital, PT and so forth. Help us with thinking about some concrete examples.
I think going back to what George just said, the program works, but it requires a significant investment. So a couple things happened. The physicians got engaged, got involved, but the reality was we had to have a significant investment in infrastructure. We added care navigators who were constantly in contact with the patient. It requires software and some tracking type navigation as well, so it's both people and technology. And so what happens is it touches every part of that patient's care, which is probably what we needed to do for a long, long time, but there was no way to do it, or there was no incentive to do it. So I think that it's really important to understand that this isn't just about cutting cost. This is about engaging the physicians in every level of their care, rather than just being more proceduralist and then just saying whatever happens, happens. Once they leave the hospital, I don't know what happens unless they come back to the office. So we really got involved in their care, not just in the acute phase, but in the post-acute phase, where 50+% of the spend was in the post-acute. So it's really important to do that, but you got to get engaged initially. You've got to make that investment in the infrastructure to do it. And that's the biggest problem with these programs, if they're going to continue in perpetuity, is they can't just lower the baseline and we get that one-time savings and we recoup some of our investment. But the investment that we have in that overhead and the people and the technology, that's a continual investment. So we still need to get that covered to be able to deliver this level of care. And I think that's the part that we're unsure of, whether we're going to be able to maintain that in the future, because if it's just a one-time benefit and then they lower that index cost or they lower the baseline, we call it the race to the bottom, then we won't be able to continue the program or continue those savings and the improvement in care because of the infrastructure costs.
So you touched on a couple of points here, most specifically around the costs and the infrastructure to stand up such an effort. But also important, as you mentioned as well, is the issue of providers being engaged in the effort. And I think what resonates is the fact that if we're able to do this, we actually improve care, which is why we're all in this effort in the first place. But talk to us a little bit, if you would, about any barriers that you might have encountered early on, because let's just say that many of us are skeptical about change, and this is a new way of thinking about care.
So all of us up here deal with physicians a lot, and a number of us are physicians. So physicians are always okay with change as long as they don't have to change anything themselves. So that's the biggest issue. So early on, we didn't perform very well, and our docs weren't engaged. They really weren't that aware of it. And once we made them more aware and made it more competitive, because surgeons are fairly competitive people, they all wanted to be in the green zone and not the red zone. And so we had to constantly give feedback to our physicians about where they were. A lot of these things were happening without any control by the physicians, whether the patient went to a rehab facility or a SNF or had home health nursing. It was just fairly automated. Once they got involved, they were able to change and really look and see where these things necessary. But it has to be with constant feedback. They need to see where they are in comparison to their peers, and see where they are in comparison to national benchmarks. I think once you do that, the physicians will get engaged.
I agree with you, Bruce. What we found is just this inherent challenge in the conversations you have with the other stakeholders. For example, hospital systems are still fee-for-service, as are the subspecialists. So they're not incentivized necessarily to be on board with some of the measures that we're trying to implement. Keeping patients out of the hospital in some ways goes against what makes a system work. We ran into regulatory problems. For example, ER diversion strategies make ER doctors uncomfortable with when they start thinking about EMTALA and how that applies. So we were trying to break down those barriers and get everybody comfortable with, what are the appropriate clinical criteria that everybody can agree upon. We didn't talk to just one hospital system. So we're engaged with all three of the hospital systems. They think differently. They act differently. They have different markets. We set up Uber. We set up cab. All those sort of things, and you run into those kind of obstacles that you never think about until you're trying to work through it.
So a lot of clearly the success depends upon collaboration amongst many who have traditionally have worked together but maybe not collaborated to that same degree.
Absolutely.
That's new work.
And I was going to add, you mentioned a term that was just floating around in my head, which is alignment of incentives. And we've talked before, Dr. Rose, about the potential cardiac bundle and the fact that a readmission brings revenue into the health system. But under the program, you don't want readmission, so where does that balance happen? And that's still a barrier. How do you figure out what's the appropriate balance for finances? If you then kind of look at case management, care management, historically case management's role has been, let's get patients out of the hospital quickly so that we can make room for another patient to come in. And that has to change a little bit, has to become more about care management. Is it right for the patient to perhaps stay in the acute care facility for a day longer to change their post-acute trajectory? And so because the incentives still don't exactly align, a lot of those conversations are still happening. And that's a challenge and a barrier that I think we'll just continue to work through.
So, along those lines, one of the issues that comes up when we think about episodes and populations and so forth is really how do we get to granular detail about an individual patient? As providers, we know that each patient is different and so forth, yet we're trying to make decisions, along protocols and along those lines. Can you speak a little bit about the importance of how we're describing our patient population, how we're documenting the things we do, and how that impacts basically the reality of the value-based world.
I would say one of the things we noticed, and this was because of the richness of the data that we had access to through BPCI, is when you really get down, I mentioned this in my talk earlier, when you get down to the outliers and those that had really high spend, the ability to drill in and see what was driving that spend. Was it the fact that they were being transferred in from a facility outside of Charlotte here and were a more complex patient? Was it the fact that we, as I mentioned, discharged them too early perhaps and they came back or had to readmit? The ability to do all of that, I think, is what will kind of push us forward and allow us to know what things we need to focus on. So I think it's extremely important. We're still getting our arms around it and figuring out what are the right things to look at, but having that patient level detail and then to your point, tying that back to how do you change and modify clinical protocols, I think is extremely important.
One thing we found in North Carolina is when we were compared to other states that had a higher penetration of ACOs and value-based care is that our coding has underrepresented the complexity of patients, and some of the modifiers that the ACOs, and I'll use California as an example, they had a higher complexity of patients according to Medicare versus North Carolina, and it has to do with the fact that we weren't used to having to put these modifiers in. So as we started to do that, the idea is that we will get a better representation of what our true cost structure is and what our opportunities are.
Yeah, and I think that becomes an important point as we're looking collectively about how populations of patients perform. We have to be able to describe with some degree of, it won't be, incredibly accurate, but it's got to be better than where we were in terms of being able to define those, those populations. Well, as we're winding up here, the Institute of Medicine tells us that our targets in terms of quality care is really the care is efficient, it's effective, it's safe, it's timely, it's patient-centered, and that it's equitable. So the question that I would ask each of you, do you see this trend, this movement towards episode-based evaluation and management, achieving those ends? And then secondly, what do you think the next step is along the way? So Bennett, I'll start with you.
Sure. I think looking at care episodically, whether that's tied to a bundled payment program or quality or patient experience, is a better way of looking at it than the incremental or the more fragmented way. So if you think historically, a hospital, you're going to look at the hospital portion of the stay. You may then look at the SNF part. You may look at physician visits. If you look at all those things collectively, I just think you can make better decisions, and the patient wins. It changes the way we think about readmissions, for example. And I think bringing it into perspective through a bundled payment program is great. We need to push ourselves as a healthcare system to begin to look at more things, more just elements of care episodically, in my opinion. And I think that will push us in the right direction.
I think somebody referred to it earlier about our traditional fee-for-service model or transactional model. I'm not going to say it's going to go away completely, but I truly believe that we all are going to be accountable for the cost of the care and the outcome. Whether it's in traditional bundles, which I think in musculoskeletal care are extremely popular and probably farther and more advanced than other types of medicine. We all are going to have to be engaged in it with the physician engagement. We're going to have data. We're going to have to think about the cost and be accountable for our outcomes. So I think that is going to be here forever. It's going to expand, and that traditional fee-for-service mentality is going to fade into the background. I just don't know how quickly that's going to happen, because these changes are hard. They require a lot of change on the physician side. There's changes on the administrative side. and it can't just happen overnight. But I think it's here to stay. I don't think it's going away.
Yeah, I would agree. I think it's a locomotive that's only going to gain momentum. I'm concerned really with, how this is going to impact physicians in the sense of we've all been trained to think a certain way, and we're going to really rock that world, and physicians are going to lose autonomy. They're going to lose control. And the skill sets you need to be successful in this and how you're going to be measured is different and evolving in ways that we don't even understand yet. I think we're going to have to pick future physicians differently, to have a different way of approaching things, and the skill sets that we all grew up needing may not be as emphasized, and new ones that we don't even understand yet are going to need to be developed.
Well, I think that the absolute need for clinical excellence remains, but I think some of the things that we haven't necessarily been incented to do or had the sufficient time to do in terms of, talking to colleagues, coordinating care in those kinds of ways. The bright spot here is, again, the patient wins when we're able to do this, as from the examples that we've been able to see here today. But you're right, it's going to take a new paradigm and a new way of how we interact as we move forward. So I think we'll close here with respect to the work that has gone on. I'd like to thank those of you who've had a chance to spend some time with us and engage in education around this topic, learning what has been happening here already in our community through the Carolinas Physicians Alliance. I would also offer this as an invitation to anyone who is interested in this kind of work to either to learn more or to begin to engage in it, to reach out to any of us on the Carolinas Physicians Alliance so that we can connect you to this work. As you've heard from our panel, this is just the beginning of what is to come as we all try to find the solutions that we're able to consistently deliver care that is of the highest caliber and is sustainable from an economic perspective. So once again, thank you to our panelists, thank you for your presentations, and thank you all for your attention today.